So I work for Children's Healthcare of Atlanta, and we have what's called a pediatric feeding disorder program. We have 3 different locations, but I put the 2 main ones here. We have one that's where we started, was at the Marcus Autism Center, which was then purchased by Children's Healthcare of Atlanta. And then this is the Center for Advanced Pediatrics, which is a large outpatient facility. We have a multidisciplinary team of gastroenterologists, ENT, psychology, nutrition, speech pathology, social work, and any other specialties that are relevant to the children that we see. We treat malnutrition, feeding tube dependence, formula dependence, and food selectivity. This is also known as ARFID, which is avoidant restrictive food intake disorder, which is in the DSM-5 under the broader eating disorder umbrella. Our main kind of program that we have is an intensive day treatment program designed to wean children from feeding tubes, wean children from formula if they're dependent at an age where it's not appropriate to be dependent on formula, and increase variety in children that are so food selective that they have nutritional deficiencies. So what happened was we were on vacation with the family, and I was telling my dad, oh, you got to see the labs for this kid that I saw. They're crazy. And so here I am now presenting to you. Was that what you wanted me to go over?
That was beautiful.
Okay.
That was beautiful. So why don't you tell them the story, and then we'll let the intern and resident try to figure out what labs to order and why, and then you can teach them and show them the labs.
Okay, so I'll go slowly and I'll pause so that I don't reveal too much at a time. Okay, so on Thursdays I do a clinic with our pediatric GI, and we see a variety of kids for medical intake. Some, have just left the NICU or cardiology cases, but in this case, we saw a 2.5-year-old boy. The only diagnosis in his chart was autism spectrum disorder. We really didn't figure out much as far as like medical issues that the child has, and we ask a lot of questions to determine, is the kid having weird feeding stuff because there's something organically going on. The only thing really was constipation. The caregivers need to use a glycerin suppository, and he vomits when he's really backed up. But this is what Charles's diet was: 16 Yoplait yogurts every day, and he only ate these 3 flavors: mixed berry, strawberry, blueberry, and his parents could get him water by syringe. So this is a pretty severe case for what I see, but it's actually not it's not so odd for the children that we see. We see a food selectivity, not usually where there's only one type of food that the child will eat. So I did a nutritional analysis, and I'll pause after this. And so basically I just put 16 yogurts in for the day to see where we are as far as meeting his nutritional needs. I didn't add a slide on this, but the child, his anthropometrics looked absolutely fine, and he was growing normally. There was no concern about that. But when I ran his diet through the nutritional analysis program that I have, this is what came up. And I'm assuming that you know, but if not, the dietary reference intake is just the amount of nutrient that each person needs based on gender, age, etc., in order to not be at risk for deficiency. So it was pretty much 0 or enough. Obviously, he had plenty of protein, vitamin D, and calcium because all he was consuming was a milk product. Okay, I'll pause because I think the next slide was the labs ordered.
Okay. So who's going first? I guess Austin, right? We always let the intern go first.
Sure. Well, I mean, I feel like this slide is a bit of a gimme because you've listed a number of the things. I mean, before we even talked about this, I mean, in the hospital, often, we're ordering vitamin B12, folate for a lot of patients because, frequently they're deficient in those, and then thiamine with the classic tea and toast, kind of picture. So those would have been mine no matter what, which you've kind of supported here as well. But things like iron and zinc for this patient, I'm kind of amazed that they are tracking on their growth curve if this has been their diet for quite a while. That was the other thing I was going to talk about, is that, you know, for any time a patient is coming in with failure to thrive, my question is going to be, are they failing to thrive, right? Are they meeting their growth milestones and all of that? So you've touched on a few of those things.
You know, I think because these only two, that I'm wondering if that's why we hadn't started, because I've seen kids with similar profiles that their growth tends to start going down this way.
So Smita, do you have anything to add?
Yeah, I think the things that stood out to me were especially the vitamin C. We actually had a case of scurvy recently at Children's. And so that's the one that stood out to me to definitely work up. And then like Austin mentioned, the iron and zinc. And so in addition to like these extra labs, obviously, I would want just a regular BMP and a CBC to make sure that we're not anemic. I think the American Academy of Pediatrics says that iron deficiency is the most common nutritional deficiency in children. And so that's something that we always look out for. And then the zinc and vitamin C are the other two that stood out to me that I would have wanted to get.
So I actually have a question for both the house officers as well as you, Rochelle. You checked vitamin B12, but you didn't check other B vitamins. Are other B vitamins important in a patient like this?
So this is just our standard that we report on for every child, because it has been what's been commented on in the literature as far as children with feeding difficulties and autism and what they're most deficient in. But in our nutritional analysis, the program looks at all of that, and I just didn't include in this report, but we would look at it.
So Austin and Susmita, is that something that you're used to? And do you have any? So Rochelle takes nutrition histories all the time. I know that y'all do too, but what questions would you have for Rochelle about how to take a dietary history and how to use it, etc.?
Yeah, I think something that I have read recently is kind of like the difference between taking like a dietary log, so like having the family like go home and like write down every meal, and that tends to not go so well sometimes versus just like an entire catalog. I think in analogous to adults, kind of how we ask patients to take a blood pressure log, and that tends to not go super well for a lot of our clinic patients. I think a dietary log, it doesn't go super well for a lot of our pediatric patients. And so I would definitely like some advice on how to better do that, because I think that's what we tend to recommend to parents, and it tends to not go over so well.
So I agree. We stopped doing like record, we used to do a 3-day record. So we do a 24-hour recall, but that actually takes a decent amount of time, and it does, in order for it to be validated, you have to really have kind of this long conversation. I really think the best thing to do for a child who is a picky eater, or you're suspecting that they're like an extreme picky eater, maybe they have a diagnosis of developmental disability, that you just go through each food group and find out if the child eats any food in that category. So say, does the child eat any fruit? Yes or no. Any vegetables? Yes or no. And if they have a food or two in each category that they eat at least a few times a week, you can feel decent that they're not going to have nutritional deficiencies. I would say the caveat being, you had mentioned the American Academy of Pediatrics. If a child's getting 3 or more cups of milk per day, they are at higher risk for iron deficiency anemia. But otherwise, I think you can just go by the food groups and just say, is your child eating anything in this category? Because the kids that are showing up with, say, scurvy or rickets, they're not eating any foods in that category.
That's really interesting, because I'd never thought of being in clinic and kind of having a template for just going through the food groups and hitting it like that. But I can see that being a pretty efficient way to get some of that information out. I feel like one of my go-tos is often like asking what some of their go-to meals in their house are. Like, can you tell me what 2 of your like most frequent meals in your house are? And if they sound like vaguely healthy, then I'm like, okay, then like you're probably in an okay trajectory. But for these, people who you're more concerned about really breaking it down by food group, that seems really effective. I'm gonna definitely use that.
Okay, so Austin and Susmita, do you want to predict the lab tests? And you got a
Want me
pretty
to
good
like
cheat
put
sheet
what
right
we
here.
ordered? I think y'all hit on everything that we ordered. Let me know when you want to go through to the labs.
So Austin and Susmita, do you have any thoughts about this?
Yeah, I'd say I probably expect this child to be anemic and then their iron to be severely low. I'd expect their vitamin C to be really low too. And then obviously their zinc level to be low.
We
But-
have a patient. Sorry, go ahead.
No, you go ahead. I'm done.
I was just going to say we have a patient right now in the hospital that has undetectable thiamine, so I wouldn't be surprised. I didn't know that we could do that, but I wouldn't be surprised if this patient's thiamine is pretty low as well.
Okay, we ready for the big reveal?
Yeah, I'll go to the other part afterwards. This is the first, and then I'll show the CBC after. I mean, I was surprised about the zinc as well. I was like, maybe I need to look at Yoplait and make sure there's the accurate information in there. And the
Yeah,
thiamine
and
was
thiamine.
okay.
Yeah.
Thiamine was fine. B12 was fine.
Ferritin undetectable. Oh, geez.
Mm-hmm.
Yeah, I feel like you typically think of, milk-based iron deficiency anemia from people drinking milk, but, you think about consuming it. I don't know how many ounces is in each of the Yoplaits, but
It's like 6 ounces in each of the
Yeah.
Yoplaits, so that's like 96
ounces of milk a day.
ounces of milk.
It's going to have an impact.
Mm-hmm. So I'm going to go to the next page.
And I just want to give a caution about thiamine levels because I'm actually have been doing some research on that recently. And thiamine levels have poor sensitivity and poor specificity. So just because you get a quote normal thiamine level does not mean that the patient's not thiamine deficient. You can also check transketolase for that, but even that's not too good. So if you really suspect it, at least in adult medicine, we just empirically give thiamine. If we have someone, and I'm sort of relating this to people who either drink too much and don't eat food, or people who, there are adults who eat really bizarre diets. And so a lot of times we worry about thiamine, and the level is not that useful unless it happens to be low.
I know as part of our just power set for altered mental status at UAB, it just has like a week of thiamine built in, not even checking at that thiamine level. So definitely addressing that with our adult population.
Do you want me to go to the next slide?
Somebody had a question about why the vitamin A is high.
I'm not 100% sure if there's a physiological process. I'm not sure of it, but it could be that my that it was fortified, like milk is sometimes fortified with vitamin A, and it could be that my nutrition analysis program just didn't have everything in it. That was the only thing I could think of. The E makes sense to me because the child was not getting any vegetable oils.
Great.
Okay.
Austin, that's what you would expect, right?
Pretty much. He's not as anemic as he could be. I've got 2 sickle cell patients I'm having on the ward right now, and they get awfully low, but 9.1 is definitely clinical in this patient.
Yeah, I'm honestly a little surprised it's not lower. So
He's only 2. Give him like, a year, 2 more years on his diet,
Yeah, that's what I think too. I think he's little. So I'm gonna tell you what we did with him.
Sure.
Okay. So he was admitted to the hospital. He wouldn't eat anything. So currently he has an NG tube, because there's really no other way to get nutrition. And then he's going to come to our intensive feeding program, but we really needed to stabilize him. Our program's not quick. You don't get a child who's eating only yogurt to be eating a well-balanced diet in a short period of time. And so from a health perspective, he needed to be stabilized. I was going to go back to one other slide. You'd asked about getting dietary intake. So really when I think about that, just asking about food groups, is that for all the nutrients, and of course I've just highlighted some of them, not all of them, like vegetables have A, C, and E. Fruits have, fruit has C. The fortified grains are where you're mostly going to get your folic acid, riboflavin, niacin, thiamine. So if you do that kind of quick and dirty, just going through each food group, and then you overlay it with something like food and their nutrients, it's going to tell you what you should be looking for. I think that's probably the quickest way to guess what type of nutritional deficiencies a person could have if they have a bizarre diet. And I'm happy to share the slides.
I'm curious to hear what your all's kind of criteria are for hospitalization. Like obviously in this patient, their hemoglobin was low and they were shown to have, proven deficiencies in a number of things. But kind of what is that line? At what point are you all saying that this needs to be treated in the hospital?
I think because this child was so resistant to eating anything different and taking medications that we really had no choice for him. Plus, given the amount of yogurt he was eating, I don't think there would be enough iron supplementation in the world to not make him iron deficiency in the absence of a better balanced diet. And trying to mix anything in his yogurt would probably make him highly suspect. And then you would get to the same answer of an NG tube because he would probably stop eating. It's pretty rare that there ends up needing to be a hospital admission. Every once in a while, an iron infusion, kind of get him patched up enough and then come to the feeding program and check iron along the way. Or sometimes it said a parent didn't know how vital it was to get like a multivitamin in, and they can get medication in. And, we don't think that children are going to have nutritional deficiencies in the United States of America. And so it could be that just with education, you say, okay, well, they can usually get the ADHD meds in. They can usually get the behavior management meds in. If they now know this is as important too, they might be able to get it in. So sometimes it's just parent education, or it's, finding like a one-off, oh, they drink chocolate milk, can we get some instant breakfast or some other type of nutritional supplement in them? So if we can be creative enough to patch them up, then they wouldn't get a hospital admission. This case was like, this is a dramatic, even for what I see, this was it was enough that I said to my dad, you got to see this case.
Somebody asked about the decision between oral and intravenous iron.
A lot of the children we see won't take it orally, so then that's usually what the decision is based on. I mean, I think the GI doc who I work with, if she can avoid an admission, she would every single time. But remember, this is a child with autism, so he has intense behaviors in life and intense behaviors as they relate to things going in his mouth.
Do you see this much in teenagers with anorexia? I mean, do you all take care of those patients too?
Yeah, usually. So if we get a strong feeling of an eating disorder, we're not going to treat because we're not really specialized in that, and that takes a very specialized team. But there is a group of teenagers that really have like that anxiety and the ARFID that I'm telling you about, where they're highly food selective, but it doesn't have that body image component. And then we'll see that too. So with anorexia, just because total calories are low, all nutrients are going to be low. But if overlaid with that is this food selectivity, then we're going to see it more. But yes, we see nutritional deficiencies in teenagers as well.
You know, Susmita, go ahead. Susmita mentioned that they just recently had a patient with scurvy, and I know that you and your colleagues wrote a review article on scurvy. Could you just talk about scurvy in kids and what you've learned over the years, and when people should be suspicious about scurvy in kids?
Absolutely. So, you know, what's interesting about vitamin C is that it's an essential nutrient because we don't produce vitamin C. And it also can happen fairly quickly in the absence of getting dietary sources of vitamin C. It can happen in 8 to 12 weeks, which is a pretty short period of time. And I guess that's why people on chips got it, because that's about as long as they were on. So if a child's not eating any fruits or vegetables and they don't have anything fortified in their diet. So the one caveat I'll say is if a kid's eating a decent amount of cereal, they're probably going to be okay because cereal is so well fortified. But if they don't have any cereal and they don't have any fruits and vegetables, like at all, they refuse it completely, and they refuse juice, we're going to automatically be suspicious of scurvy. And I would say we end up diagnosing it like before their clinical symptoms more than one would imagine. But working with one of the hospitals in our system, I started working with one of the dietitians there a few years ago, who actually now works for me in our program. But what was happening is they had a few kids like back to back who had autism, who were presenting with refusal to bear weight. So I'd say the bear weight and the bleeding gums obviously is a classic symptom, but refusing to bear weight in an otherwise healthy child with autism would be a big reason. But honestly, not eating fruits and vegetables and not having anything fortified, I'd be suspicious just because it can happen pretty quickly.
Do we have any other questions about this in particular from the chat, or someone who just wants to turn their mic on and say hello?
Rochelle, can I ask what is like a part of y'all's intensive feeding therapy, and then what a threshold is for like G-tube placement for y'all?
What do we do?
Yeah. And then,
Okay.
like what a threshold for like G-tube placement is in a patient like this.
So in our program, we really are treating more chronic feeding problems versus acute. So it's a behaviorally based program that's rooted in applied behavior analysis, but it's like a little kinder, gentler than some applied behavior analysis gets thought of. But we do 4 therapeutic meals per day, 5 days a week for 8 weeks, slowly increasing the amount of new foods that a child's eating and the variety that they're eating. But we go slowly, because if you flood a child, they're just going to shut down and they're not going to do well. And our goal is for them to have long-term success so that they don't have nutritional problems. So our threshold for a G-tube would be, it's honestly less with this population of the extreme food selectivity, the extreme pickiness, because for most of those kids, we can be creative enough to patch them together. This was a more extreme case. So if a child's really only eating 1, 2, 3 foods all in the same food group, you can't mix anything in, they're refusing vitamins. You know, I had a child who was only drinking rice milk. So on top of all the nutritional deficiencies, they also had protein malnutrition. Actually, their hair had gone white. So in those cases, you would need a G-tube. We most often end up recommending, so many of the kids come to us already with a G-tube because they're post like NICU babies, or, you know, they had cardiac surgery very soon after birth, and for all the reasons that they would be orally defensive, they are. But for the kids that we're going to recommend a tube are those kids that we think are at risk for refeeding syndrome. And we need to stabilize them because we're an outpatient program. We're not taking refeeding labs all day long. And so if a child starts doing behaviorally really well and eating really well, we need to refeed them before they're going to come into our program. So that would be really the only reasons.
Hi, Rochelle. This is Drew Srinivasathar, one of the med peds PGY1s at Western Michigan University. So it's interesting that you mentioned rice milk. As a med student at MCV, I actually had a patient who on the ped service who came in whose mother was giving her rice milk because she was, it was essentially the only thing that she'd be able to tolerate. We ultimately ended up diagnosing that patient with a pretty rare metabolic disorder, which like a 1 in 30 million fatty acid disorder. But I was wondering, like, just in terms of cultural context, like, how do you go about talking with parents about sort of getting adequate nutrition for their children, for like, say, in the context of affordability of food, like living in food deserts, or just cultural ideas about what kids should be taking in?
Yeah, great question. So first of all, we're really fortunate to have an amazing social worker on our team. So that is really helpful when it comes to kids and making sure that kids have access to, WIC, if that's the correct age, school lunch, formula access, things like that. Parents have a lot of ideas, as do adults, about what is proper nutrition and what isn't. What I usually do is, first make sure that I'm meeting a family where they're at. I have the benefit in the day treatment program of working with them for 8 weeks. So they get to know me and I get to know them. And it's easier to be kind of pushing the conversation, if you will. And then we have so many different, like, a lot of people are against cow's milk. Like, that is a pretty popular idea. So then I'll just spend time going through other milks and saying, like, well, almond milk's an option, but also soy milk is going to have better protein. I'm worried about your child's protein. So really doing that from a very specific way. I'm worried about these 3 nutrients. Let's see if we can find something for these 3 nutrients, rather than I'm going to tell you everything that you're feeding your child is wrong. So really focusing on what the true problem is. With regards to the food deserts, we spend a lot of time really finding out what the family has access to. And we recently had a pretty sad child who was in Child Protective Services, but he really had access to what I would call like gas station type of food. And so we focused on like fruit cups, because you can usually find that. You can usually find bananas in places. And so we only focused on working with him to eat foods that he was going to be able to find in life. We didn't do asparagus with that child because likely that is not going to be something that he's going to be able to easily find due to his circumstances. I would say most parents, once they realize that I'm not just going to dictate the diet, but I'm going to ask them questions about what they eat and they're comfortable with, I don't run into problems.
Rochelle, do you have many parents who try to give their children vegan diets or at least vegetarian diets, and does that cause problems?
Yes, I do have some parents, not some vegan every so often, but vegetarian. And often, honestly, what we'll do in that case is just do labs, because we really want to figure out if we put together a diet that we think is going to meet all of their needs. And if they're still insistent on not doing it, we say we're going to have to follow them really, really closely, and make sure that they're not at risk. If the child's growing well and they're willing to eat enough of the variety that we can put it together, it's hard to make a case to say, no, you can't feed your child that way. But if the child is already coming in very food selective, we can usually suggest they're really food selective. They're not going to be wanting to eat, beans as their primary source of protein. It can be a tough food for a child. But it all takes a delicate conversation. That's the best way to say it.
Do y'all have any other particular questions? Rochelle, I think we're going to do an adult case now, and we'd love to have you stick around if you don't mind.
Yeah, I'd love to. Okay, I'll stop sharing.
I also just want to say that obviously in the outpatient setting or in the inpatient setting, if we got a patient like this, we would be consulting a dietitian because that's who should really.
Yeah, I would highly recommend that.
Okay, Lindsay, was it you and Natasha?
Natasha's presenting the case, and Ben is going to share his screen
Great.
and type it up for us.
Hi, everyone. I'm Natasha. I'm one of the second-year medicine residents. Okay. So I have for you guys a 72-year-old African-American female who came in with a chief complaint of feeling weak. Would you like a little bit more history,
Sure.
Dr. Centaur? Okay.
Sure. I guess I'm on the spot.
Make
Or
it bigger.
whoever, yeah, whoever has questions. So I'll give a little bit more history.
I think we have MedPeds intern and resident there, and so they can handle adults as well as kids.
That is true. Okay. So this is Mrs. H. She says that she came in today after falling and hitting her head. She denies any kind of syncope, her head spinning, or anything like that. She says that she simply just felt weak and lost her balance and is having back pain from when she hit her back.
Okay, Austin.
I know I looked at it. I watched a couple of the previous episodes, and we like started with the labs. Are we going like classic through the history, or are we jumping straight to the labs? Which are we?
I was hoping to go through a little bit more of the history, and then I'll
good.
give you labs within a couple of minutes.
Sounds good. No worries. Just checking in.
I don't want to give it all away right at the beginning.
Thank you to whoever made it bigger, so I can read it better.
Sorry about that.
So we've got a patient who came in. So like I'm thinking through, is this headache piece from like is the falling really the problem, or is the fatigue that's the problem, which are like kind of different issues? But it sounds like this person's not having. Did they have any headache at all?
No headache.
Okay, so really it's the fact that they fell that came in. And was this their first fall? Have they had other falls recently or weakness?
Yeah, first fall, but feeling weak and fatigued for kind of, I would say, a subacute time period. She couldn't give me an exact number, but for at least the past several weeks.
Yeah. So, fatigue, falling, like B12 anemias, or like, starting to think through deficiencies and things like that in terms of these labs and this, type of picture. But also anything else that would be causing paralysis or weakness in a patient. Do they have any like back pain or focal things they've noticed?
Yeah, a little bit of lower back pain, but on physical exam, she doesn't have a hematoma. She just has a little bit of tenderness and no focal neurological deficits.
I guess, Natasha, that was my question. Is she weak all over, or is she weak in like certain extremities, any numbness or tingling in extremities?
Yeah, so she denies numbness and tingling, and she endorses a very diffuse weakness and isn't really able to characterize it. And you can tell just talking to her that she's kind of fatiguing.
Has she had any bleeding recently?
Yeah, so we asked about overt bleeding, and then we asked about melena or dark stools, hematemesis, anything like that. She denied all of that.
Any blurry vision?
No blurry vision.
That's a really good question, Susmita. Why did you ask about blurry vision?
So, so I know that we're talking about nutritional deficiencies here, but if I'm broadening my differential for an elderly woman with weakness, I think about like primary neurological issues. And so a patient with blurry vision, like I think things that are going to kill you first, so hemorrhage in the brain or stroke or something like that, it's going to cause some blurry vision.
But some nutritional deficiencies will cause blurry vision.
Mhm. And I guess going along with our nutritional deficiencies, any diarrhea, constipation, anything like that.
So when she came in, I specifically asked her about diarrhea and she denied it. But on hospital day 1, she had 4 bowel movements charted. And so at that point, she's like, oh, well, it's not really diarrhea. I'm just having like multiple bowel movements a day. And so after that, getting a little bit more history, we got her to open up a little bit. She was a little timid, and she actually mentioned that she hadn't been eating because every time she ate, she had a bowel movement. And so she had been avoiding eating.
And then my last sort of targeted question would be like a rash. Does she have a rash anywhere that she's complaining?
No rash.
I had one question, Natasha. Does she have any cerebellar signs like loss of balance? Is it just weakness or is it a balance problem also because she fell?
Yeah, no, it's just a weakness problem. No ataxia.
Before we talk more about the diarrhea stuff, I was also going to ask about mood, because I know that depression can be like a common cause for malnutrition if people aren't eating enough as well.
Yeah, so she doesn't have a history of depression, but I think just from being so fatigued and in bed all the time, her mood is a little bit down. But I wouldn't say that she's depressed, because when anytime family came and visited her, her sister spent some time at bedside her, she would perk up. So I think it was all kind of secondary to the fatigue.
Another good question is B symptoms. And while I'm interested in fever and stuff like that, I'm really more interested in weight loss. So you said she hasn't been eating. She's had this diarrhea. Has she lost much weight?
Yes, she said she's had what she says is unintentional weight loss. She's not able to quantify, and the last time she's been at UAB was 2004, so we don't have a previously charted weight from her. Let me tell you what her BMI was, about 21 when she came in. But she says she used to be much bigger.
Okay, Austin and Susmita, what are you thinking before we get some labs?
So Austin, go ahead.
Oh, yeah. I mean, I think a big piece of this at this point is the diarrhea is a big part of this. So all the kind of diarrhea things, IBD, IBS, celiac, are some of the things that are coming to mind.
And yeah, thinking about nutritional deficiencies that can cause diarrhea and weakness. So I think a lot of the like B vitamins can do that, if I'm not mistaken, can cause those symptoms. I'd like to know like what kind of came first. Like, is the diarrhea what is causing her to be malnourished and that is what's causing the weakness, or is the diarrhea a symptom of nutritional deficiency? I haven't fully teased out yet.
I was also,
Yeah, and that's oh, sorry, go ahead, Austin.
I was just going to say, I mean, also somebody who has had lots of weight loss, fatigue, now lots of diarrhea could fit with HIV as well. So obviously this would be a late age for HIV AIDS, but possible.
Yeah, so Susmita, to answer your question, she thinks that as far as she can remember, that she's been avoiding eating. 1, she's had a decreased appetite, and 2, she's kind of scared to eat because she's tired of having to go to the bathroom so much.
Should we get some routine labs and see if that gives us a clue? Is she on any medications? Because sometimes medications can cause nutritional deficiencies.
It's a good question. She was not taking anything except just like over-the-counter Tylenol when she came in.
How did this
She's
person
been
get,
out of touch with the healthcare system for several years.
I was gonna say, how does a person get to 72 and not have any medications? Like, hashtag goals.
Has she had any gastric surgery by chance?
No.
Thank you for asking that question. It's always a good one.
That pernicious name anemia, it'll get you.
So let's assume that this is a nutritional problem. What is your differential now?
Someone asked real quick in the chat about alcohol use. So she does endorse drinking 3 to 4 times a week. She says she has a couple of shots of vodka with her sisters and their husbands.
Any other drug use?
No tobacco use, no drug use, and really no past medical history either, no surgeries. And she said just blood pressure, high blood pressure and diabetes run in her family.
Okay. What could it be, Austin?
I mean, I'm still coming back to B12 deficiency because it could explain neuropathies as well as anemias, those sorts of things for fatigue. So,
And it can also cause a lot of neurological problems. And remember that I've seen the number quoted that 25% of people with B12 deficiency have normal CBCs with their neurological deficiencies. And I have diagnosed that a couple of times in my career. So I like the idea of talking about B12. What about are there other B vitamins that we have to worry about?
I mean, we could talk about folate as well, but it's not going to cause the neurologic symptoms we're
Right.
expecting with this weakness. So,
Susmita, do you have other
Yeah, I think
thoughts?
doesn't B6 also, it's like the dementia, dermatitis, diarrhea
Mm-hmm.
can do that. And then I guess some of my thought, like if the diarrhea came first and is what's causing, or nutritional deficiency that's causing the weakness, I guess, like some sort of colitis that's causing malabsorption, like she can't absorb as well in the small intestine or
like tropical
nutrients
sprue
probably.
and things like
Yeah.
that.
Yeah. Probably be a little old to have developed celiac. Probably. I don't think I can't make a case for scurvy. This doesn't have a scurvy sound to it. Micronutrients, probably not. Well, let's see what the labs look like. Anything
guys-
peculiar on physical exam?
No.
Okay.
And it still could be IBD in a patient as well if they had IBD first and then nutritional deficiency second. So
I guess the biggest thing on physical exam would be the neuro exam. Since could you demonstrate the weakness?
So she had a little bit of just kind of lack of effort, but when you motivated her, she had 5 out of 5 strength. She was worried. She was considered a fall risk, so we didn't initially assess her gait. But when physical therapy and occupational therapy came and evaluated her, she was steady when she was walking, albeit very slow to get up. And then no ataxia, nystagmus. Her neuro exam was surprisingly unremarkable.
Okay, well, we have about 10 minutes, so let's go ahead and get to the labs and see if we get a clue.
Yeah, do you want to start with a CBC BMP?
Sure.
Okay, I'll start with a BMP. Her sodium was 135, K was 2.3, chloride 102, bicarb 18, and then BUN and creatinine were 9 and 0.63, and her glucose on her BMP was 96. I'll go ahead and give you guys a MAG because I feel like those should be included with a BMP. Her MAG was 1.1.
I was not able to write down any of that because I'm having some technical difficulties.
Hey,
Well,
That's
Natasha, can
okay.
you?
I can put it in the chat as well.
Yeah, I was about to
And
just
then-
like hand type it out because
yeah, we have a rookie running the board.
You're
And
doing great, Ben. Natasha,
just like
can you just
Austin
give
is a
us,
rookie.
Natasha, can you just give us like the abnormals and then he can type it down below? Hold on. Wait, see if you can get like a little space to type it down below. Yeah, there you go. Now just the abnormals and then we can keep going.
Yeah, I put them in the chat too. The K was
You did? Okay, cool.
2.3. The MAG was 1.1.
The bicarb was abnormal.
Yes, it was 18. That was also abnormal.
And what was the chloride?
102, which I believe is
18,
normal for our
102,
assay.
120, gap of 15. That's a little bit
Mhm.
elevated. Not
So
too
the
bad.
labs that are showing in the grid are not this patient's labs. They're just
Right.
no.
Okay. Okay. All right.
And then I'll give you guys a CBC. So her white count was an 8.10 with a normal diff. Her hemoglobin was 4.3. And then her platelets were 12.4.
And do you have an MCV?
I do, it was 76.
Okay, team. It's a great question, Alex. He wants a description of the diarrhea.
Yeah, so she states that it's just brown, somewhat watery stool, but she still has occasional formed bowel movements.
So Sesmita, I mean, Austin's only been an intern for like 3 weeks. Help him out here, teach him.
Okay, well, Austin, that's a low potassium, in case you were wondering. And looks like relatively normal white count, very low hemoglobin. And then I always forget MCV, but I think is that low normal MCV?
That's low.
Is that low? Okay. Austin knows more than me, to be honest. Yeah, so low MCV. So I'm definitely microcytic anemia. And then
The platelets are only
low
12.
platelets.
The platelets are 12.4, not 124,
Yes.
correct?
Yeah, that's what I thought I heard, 12.4, which is
And the
really
magnesium was low. Did we have a calcium?
7.4.
Okay.
And
do we have an
albumin was 2.7 if you want that as well.
Hmm?
I
What was
said
two-
albumin was 2.7.
Okay.
What was the magnesium again?
1.1.
Thank you.
Okay, so we got to figure out what's going on, and we don't have very much time.
Yeah, I'm not sure. I'm the platelets. Like I feel like there's lots of things for the anemia, but I feel like tying in the platelets to that is what I'm struggling with. Because I mean, at first I see microcytic anemia. I'm thinking, okay, maybe this person's having, chronic, small amount of blood loss, long term, right? This lady's 72. You think it could be colon cancer, and lots of other things. But the platelets is what is throwing me off.
Okay, so does the MCV rule out B12 deficiency?
Definitely doesn't help.
Doesn't help. No, so we'd like to see high MCV, but it's certainly possible that there's more than one nutritional deficiency. And so what if if you have iron deficiency in B12, you still might have a very low MCV. She might be losing blood in the diarrhea, but it was watery diarrhea. It was watery diarrhea. So you could do stool studies and try to decide if it's an osmotic diarrhea or not. Did you do stool studies?
We did, and her C. diff came back positive.
Or C. diff came back positive?
Yes.
Okay.
That was the first study to come back, and I honestly did not write the other ones down.
How long has this person had diarrhea for?
She says like 3 to 4 weeks. And interestingly, she was not on a proton pump inhibitor. She's not on antibiotics.
Yeah. So
So
there
her
is,
only risk factor was age. She lives at home with her sisters. She's not in a group home or anything like
Yeah.
that.
there is community-acquired C. diff. It's well reported in the literature. It's uncommon, but it does happen. Could the diarrhea be the cause of the electrolyte abnormalities? So the electrolyte abnormalities can cause the weakness. We could blame the weakness on the potassium and the magnesium easily, right? And it sounds like she really has diarrhea because her bicarb is 18. Now, I'd probably geek out and get a urine anion gap and document that it really was diarrhea. If it was not diarrhea, what might it be? We'd have to give her renal tubular acidosis. And why would she have renal tubular acidosis all of a sudden at age 72? That's just sort of hard to figure out. So for treatment, you're just going to go ahead and give her magnesium and give her potassium. I'd get an ionized calcium. Her albumin's low. She hasn't been eating. We're going to treat the C. diff, but I'm still going to check B12 and iron binding capacity. And because she hasn't been eating much, I'm probably going to, I've become totally obsessed with thiamine, and I'm probably, with her not eating, you can get thiamine deficient fairly quickly. And I probably would empirically just give her some thiamine. Checking labs is not as useful from everything I'm reading. So I'd probably just empirically do that. So what about B12 and folate and iron?
Yes, so I'll give you all of those. So her iron was less than 10. Her ferritin was 9, which are both very low.
Yeah.
And then her vitamin B12 was greater than 1500, which obviously is normal. And then folate was 7.8, which is also normal.
Can that iron give you thrombocytopenia? I know B12 can do it, but I don't remember iron doing that.
It shouldn't. And I can tell you what we did next unless you have more thoughts.
Well, since it's 7:56, why don't you teach us, Natasha?
Sure. So initially we were concerned about, we were trying to decide, is this 2 separate processes? Does she have iron deficiency anemia from either a GI process or her diet? And is the thrombocytopenia related to her alcohol use? So we got a right upper quadrant ultrasound, which did show cirrhosis, but we kind of unanimously decided as a team that platelets of 12.4 from pretty mild cirrhosis don't really make sense.
Right.
And we were actually concerned for bone marrow pathology. The only part that didn't really fit was that her white blood cell count was relatively high, but we decided that she had C. diff, so maybe she's mounting, this is like a relative leukocytosis for her. And so we ended up consulting hematology oncology. And kind of in the meantime, as we were talking with them, we got an FPEP and UPEP, which didn't show anything. And then we actually ordered some other nutritional labs as well. So we got a zinc and a copper. And both of those were borderline. Zinc was 66, lower limit of normal is 60, and copper was 74, and the lower limit of normal is 70. And she had been on a multivitamin for a couple of days after she had gotten these. And so we called HEMONC, and actually I think Dr. Jory May was on service, and they actually said that this was all nutritional secondary. They thought specifically to the copper deficiency.
So
So
copper deficiency usually gives you megaloblastic anemia, right? Doesn't it?
Yes, it can give you
acts like
sideroblastic
B12.
anemia.
Well, we said before, because of the iron deficiency, that could mask that.
And how iron deficient she was, exactly.
Yeah.
And so,
Fascinating.
yeah, copper deficiency can cause thrombocytopenia pretty severely as well. And so we continued her on a multivitamin and treated her C. diff. and ended up discharging her. Unfortunately, she came back 5 days later for a different problem, but her hemoglobin had improved. She had gotten a couple of transfusions when she left, and on the day of discharge, her hemoglobin was 9.9. And when she came back almost a week later, her hemoglobin had improved to 12.1, and her platelets went from 12.4 to 41.9. And she came in with seizures, actually, which was completely what we think is unrelated to her initial admission, because she had been discharged to a SNF. So we happened to get those labs when she came back.
Excellent. Well, we could probably talk about this for a long time, but I hate to keep people too long. It is 8, but why don't you just share with us the biggest things you learned from this patient, Natasha?
So I learned just to always, one, order a C. diff, because it was kind of an afterthought, because she stated her bowel movements were pretty formed. And I remember I was leaving for the day and I was like, let me just order it. And when I came back in the morning, she was on contact precautions because it had come back positive overnight. So I think low threshold to think outside the box, especially the nutritional deficiencies. I've never seen copper deficiency, zinc deficiency. And honestly, I've erred on the side of doing like a broader workup when people come in since then. And I've had a couple of other interesting cases as well.
And Susmita and Austin, you both have done a great job today. Why don't you just share what the biggest lessons you learned from the 2 cases? Austin, you have to go first because you're the intern.
Love it. I think I really love the tip about taking the nutritional history. I think that targeting in on the food groups as somebody who will have to do a lot of pediatric histories with my kids, I know that that'll be a really impactful way to do things. And in terms of this adult case, I think that often when people come in with weakness, falling, you are drawn to a lot of the more neuro-based things. We want to get an MRI, that kind of thing. And I think that broadening it out to more of the nutritional things, I think is really helpful.
Susmita?
Yeah, I think definitely thank you, Rochelle, for teaching me more about how to take a nutritional history, because I feel like I do a terrible job of that in our primary care clinic, but that's mostly what we do a lot of what we do in our primary care visits on the feed side is nutrition. And so that was super helpful. And then I think the reminder of like, Natasha, these like weird deficiencies, because I actually had a patient on renal warts last month that was weak from copper deficiency too, and that was kind of an afterthought for us. So I think important to think about those things when a patient comes in like that.
Rochelle, thank you so much for joining us. Why don't you give us your last message to all these physicians about what we should know about nutrition and about the role of experienced dietitians?
I would say the biggest thing, and I think Susmita, you might have just, or someone touched on it, is that asking about nutrition is super easy, and it really doesn't take very long, and it's way less expensive than ordering MRIs and X-rays and things like that. So if there's any thought that there would be a nutritional reason for altered labs, that's a good place to start with any patient.
Great. Lindsay, do you have any final comments?
No, just thank you all for being here. Great cases, great discussion. It was a blast.